Good morning, everybody. Today I'll be talking something about renal stones. I'll be stressing some parts about it which I consider to be more important. So let me share the slide. Oh, right. So uh, yes, I'm hope that you can see my screen, and that's what I'll be using throughout. Okay, so this about renal stones. This is a pretty old disease. I mean, there's been no time when stones were not, people were not suffering from stones. And Hippocrates also mentioned that I will not cut even for the stone, but leave such procedures to the practitioners of the art. That means doctors should not treat stones. But it is that was a problem at that time. Surgery was not well developed. So if anybody tried to operate for stone disease, the patients usually died or they had horrible complications. So Hippocrates said that a physician, a real doctor, should not actually cut for stone. If you read his in the Hippocratic Oath, then you will find that it is mentioned there. Nowadays, everything has changed. We have it's a much more scientific method we apply, and naturally, surgery is the mainstay for management of renal stone. Medical management forms a very, very small role in the management of renal stones. Now, prevalence is pretty high, 2 to 3%. It may be up to 5% actually in India. 2 to 3% is the established data. And as you know, many times the stones pass on themselves. They may be small, they pass by themselves, but they recur. And without any specific measures being taken, so the person continues as before, the recurrence rates are high. So 35% at 5 years may be actually up to 50% at 5 years. That means half the persons who had a stone which passed out spontaneously would have another stone by the end of 5 years. And unfortunately, for the most common group of stones, that is calcium oxalate and calcium phosphate stones, currently the therapy is aimed at treating the stone, not at preventing their formation. There are certain things which we can do to prevent it, and if we know which type of stone it is, then specific management can be done. But largely we cannot prevent stones from forming, because the basic problem, the basic pathology is we are not correcting that. If it's a genetic factor, we are not correcting the genetic factors. If there's a metabolic factor, we are not correcting the metabolic factors. So if there's a certain disease like uric acid stones, you can actually control the increased uric acid excretion, so they can be treated medically. Otherwise, the most common group of stones which we have, we are actually treating the stones, we are not treating the disease. So what are the various factors? Now I'm talking about the predisposing factors here. Remember that this is not an all or none law here. So although it is rare in Native Americans, Native Africans, Native Israelis, and more common in Asians and whites in temperate regions, it does not mean that if you are an Asian, you are going to get a stone. It just means that you have a statistically higher probability of having a stone. And we have other genetic diseases like familial renal tubular acidosis, cystinuria, or hereditary xanthinuria. So these are factors which can cause increased stone formation. These are specific stones like xanthine stones or uric acid stones which form in these cases. Higher age in the 20s to 40s, that is the most productive age group. Why it occurs in the 20s to 40s? Maybe it is just because this is the age group which goes out to work more, gets dehydrated more, so therefore the chances of stones are more. So that may be the reason. But yes, what is seen epidemiologically is that it's high in the 20s to 40 age group. Although there is equal tendency in childhood, men are more likely to develop renal stones. Is this because when we take the world as a whole, the men go out more to work and that's why they get more dehydrated? We don't know as yet. This data has not been corrected for that. But in general, we find that more men come to the OPD with stone disease than women. But if there is a certain disease in which there is hypercalcemia per se or hypercalciuria, like hyperparathyroidism, then naturally that would be affected more. And hyperparathyroidism is much more common in women. So if we see that whether these are known as secondary stones, so if the person has got hyperparathyroidism, so then women are more commonly involved in such cases. There are certain reasons which are hypothesized for that. That maybe is the effect of testosterone or because its citrate levels are higher in women. We don't really know about this. For mountains, desert, tropical areas, you can understand warm areas, more sweating, more evaporation from the skin losses, insensible losses, less urine output causes more likely stones to form. Some climatic and seasonal variations, which are very easy to understand. Now, this is something very important for the patient or the sufferer to understand that the colics, the patients develop colics after a few months of the peak summers. So many times people come and say कि देखो जी गर्मी में तो मुझे कुछ हुआ नहीं, अब देखो बारिशें शुरू हो गई हैं और थोड़ा मौसम ठंडा हो गया, अब स्टोन हो गया। और ये और जैसे कि मैं एक हफ्ते से या 10 दिन पहले मेरे को दर्द हुई थी, मैं तब से तो पानी अच्छा पी रहा हूँ और मेरे को फिर भी स्टोन हो गया। So the it's not like that. The stone formation has started a few months prior to the person's getting the colic. So they have to be told in the next year, in the next season, they have to ensure that their fluid intake is high from the beginning of the summer season itself, because the summer season, like in Delhi, it would start in April onwards, and they will come to us with colics in the monsoon or maybe in the autumn season. And the reason is obviously that stone takes time to form. They get develop symptoms later, but that much time has passed for the stone to form, and the person has been dehydrated through that whole period, and that is why the patient is getting the increase in size of the stone. Water intake definitely has a role to play by simply the dilutional effect. So crystals may form in many persons, but whether they aggregate to form stones is dependent on whether the dilutional efficacy is there or not. So if the person is having a lot of water, a lot of urine output, the crystals tend to get diluted and they are passed out through the urine itself. But if there is inadequate dilution of the crystals, they tend to aggregate and form stones, and they keep on enlarging after that. And some dietary factors. So rich in purines means that ultimately uric acid is found. Oxalate naturally oxalate stones, calcium and phosphate stones as such. Now I've mentioned here because it's given in the book that the vegetarian diet have childhood urolithiasis or like habitual excessive ingestion of milk and ice cream products, but this is not defined as such. So what would you call as excessive ingestion? I might say that more than 2 liters per day for months altogether might cause excessive, might be labeled as excessive ingestion. Or more important is people who chronically or without any reason consume tablets of calcium and vitamin D3, high doses of vitamin D3. So vitamin D3 actually conserves the the calcium, but after a certain level, when the calcium intake is also high, the excess calcium has to be excreted in the urine. So after that, the excessive calcium intake is excreted in the urine, and then after that, the stone formation is high. Sedentary people like us are definitely more liable to form stones. And one thing which has been found to be important is people with a higher strata of society. That means whose incomes are higher have a higher tendency to develop stones. It is possibly related to the diet. As our diet changes when the disposable income increases, so more junk food, more of protein-rich food is taken, more of dairy-rich food is taken. So possibly that contributes to the formation of stones. So what is actually happening? Try to understand more rather than once you try to understand what I'm trying to say, you'll find it easier to read in the books, also understand what is being written in the books. So in the urine, you have some, you have definitely fluid, you have some organic material, and you have these ions, calcium phosphate and oxalate and so on. These ions are present. And in addition to that, you have some factors which prevent stones from forming. So these are the anti-stone forming agents. Now let's go stepwise. What happens? Water definitely is a medium. So water is what carries everything. If water is less, the concentration rises, the chance of stone formation is high. Now the organic compounds which are present forms a scaffold. The organic compounds may be just like hexosamines and other hexoses, phospholipids, and other organic chains. Now they form the scaffold or the matrix. 5 to 10% of a stone is formed of matrix. Now the matrix is required for the rest of the crystals to aggregate. So a matrix, a scaffold, is formed by the organic material, in which normally the stones would collect. Sometimes what happens is the calcium and phosphate is not deposited on the matrix, the organic matrix, and the organic matrix exists as such, very rarely, but it exists as such. Now this happens in reoperative cases. Patients has previously been operated for stone disease, and you find now there is some filling defect there. Maybe an ultrasound you find there is something there, or it is a patient with say chronic pyelonephritis, chronic infection. They can develop these sort of a matrix stones. These are known as matrix stones. So they're rich in matrix, that is, they're rich in organic material, but they're very poor in ions like oxalate and calcium. Now, if they're poor in ions like calcium and oxalate, they are going to be radiolucent. They will not be seen on X-ray. So how are they picked up? You do an ultrasound or you do a CT, you find there is a filling defect, there is something lying over there. Now the difficulty for the treating person is that is it actually a clot or is it a malignancy, because there is no calcium there. So the differential of these is a matrix stone. Okay, so but these are usually seen in reoperative cases or in the presence of chronic infection. Now you have a matrix there formed of organic material, a scaffold. Now you have the ions. So the ions are the calcium and the oxalate and then the phosphate. These are three most common ions. They remain in solution. Crystals form, they pass out. Crystals form, they pass out. Now there are various theories to explain why the crystals actually aggregate together. None of them can actually explain why this happens in all the patients. In general, when the concentration product exceeds a certain limit, so concentration product is the product of one ion and the other ion, like the calcium and the phosphate. So if you multiply these two together, so if only calcium increases, phosphate does not increase, or if only phosphate increases, calcium does not increase, stone formation will not occur. If both of them increase after a certain level, then the stone formation occurs. Then they have a crystal formation occurs, crystal they aggregate together, and ultimately stone formation occurs. Now inhibitors prevent this, and most commonly is citrate. So high levels of citrate will prevent stone from forming. That's the most common anti-stone forming agent present in the urine. So it's a very complex play. So genetic factors are also involved. So it's a very complex play. You might have patients who have low citrate levels in the urine, but they don't have stones. You might have patients who have a high concentration product, but they don't have stones. You might have patients who have hypercalciuria, but they don't have stones. On the other hand, you might get patients who have all these factors are normal, but they still have stones. So, but in general, I'm telling you, so this is the process which is followed, and the reason why stones forms de novo. The very important factor for us as physician and surgeon is to remember that stasis always will promote stone formation. So whenever there is urinary stasis anywhere in the urinary system due to any cause, that will promote stone formation. So how can stasis occur? When there is obstruction due to some other cause, like there's a pelvic-ureteric junction obstruction. So there is stasis of urine in the renal pelvis. So stone formation is higher in such cases. If there is stricture of ureter, stone formation will occur proximal to it. If there is a bladder lesion like tuberculosis of bladder, which causes urine to be stagnate in the ureter kidneys, it will cause stone formation there. If there's a prostate enlargement causing stasis of urine in the bladder, it causes bladder stones to form. So for us as surgeons, as physicians, remember that stasis is something which we have to prevent, and infection. These are two factors which promote stone formation a lot and which we can actually control or correct. So hypercalciuria is the predominant factor which has been found in patients of stones. But how do you define hypercalciuria? The daily excretion of calcium more than 200 milligram. So more than 200 milligram per day of calcium. But if the person is popping calcium pills, then naturally the calcium output would be high. So the intake has to be defined. So for 400 milligram calcium intake and 100 milliequivalent of sodium for 1 week. These are not tablets. This is on the standard diet, which is limited to about 400 milligram calcium and 100 milliequivalent of sodium diet. And even then, if the excretion of calcium is more than 200 per day, we would say that the person is having hypercalciuria. Now, this may be of three types. Absorptive. The GIT is absorbing more calcium than ever. So there is some problem in the cells which are lining the intestine. They're absorbing more calcium. Now the calcium has come into the blood, but the homeostatic mechanisms in the body say we don't need so much calcium, so it has to be removed, so it is excreted from the kidney. So more absorption from the bowel and more excretion from the kidney. Resorptive is when the bone is getting destroyed. So calcium is being mobilized from the bone itself. So it happens in paralyzed patients, bedridden for a long time. So bone starts getting demineralized slowly, but all that calcium is coming into the bloodstream. So that is increasing the serum levels of blood. So increased serum levels of blood put into place the corrective mechanisms, and the excess calcium is excreted from the kidneys. So absorptive and resorptive, these are the two types of hypercalciuria. The third is idiopathic, and this unfortunately is the most common cause of hypercalciuria in stone formers in the patients we see in the OPDs. So that is the reason why we don't actually go for extensive tests. We don't actually test for whether it is absorptive or resorptive types of hypercalciuria and calcium stone formation in patients with stone, because the large chunk is idiopathic. Secondly, resorptive is obvious from the history and the presentation of the patient. They would have bone mineral density is low. They would have history of being bedridden, right? So these are that is why we don't get the assessment for whether there is hypercalciuria, number one, or whether what type of hypercalciuria is in patients of stone disease. Hyperoxaluria may be just a hereditary disorder, or it may be acquired like in a short bowel syndrome. So we do a resection anastomosis due to various causes, Crohn's disease, tubercular perforations, enteric perforations, that is because of typhoid, tubercular strictures. So when we resect it, if the length of the bowel is too low, and by too low I mean about 150 centimeters. So if small bowel remaining is less than 150 centimeters in length, it is defined as a short bowel syndrome, and that can cause excessive oxalate levels. Now that excessive oxalate levels in the blood is excreted in the urine, so there is hyperoxaluria. So this becomes a type of a secondary stones formation. And these are other factors also. Uric acid stones would form if there is hyperuricosuriia, like in gout. Uric acids also increase like after chemotherapy. Whenever there is cellular damage, cells are destroyed, purines are destroyed, metabolized, they result in uric acid formation. So somebody who has a very high animal protein diet, so that animal protein is broken down high uric acids. And if the citrate levels are low due to poor intake, in the urine, or their magnesium levels are low in the urine. So these also would promote stone formation. Renal tubular acidosis is a congenital disease, and infection and urine stresses I have already mentioned. So the commonest stone is a calcium oxalate stone. It is a very hard stone, possibly the hardest stone commonly seen. And normally it is whitish in color. But what happens is that it is covered with spikes. So think of like the coronavirus spikes. So the spikes of the coronavirus, you can see over the surface, there is something which is protruding out. So similarly, in that way, the stones are covered with spikes all over. So those spikes are sharp, and it's a very hard stone. They keep on abrading the urothelium. So if they're present in the renal pelvis, they impinge on the the urothelium of the renal pelvis, and they cause small injury there, and which causes bleeding. Now that blood gets incorporated in the stone as the stone grows, and it becomes brownish in color. Okay, so you may get a dark brown or light brown stone commonly seen, and the patient may actually present with hematuria. But the stone, the calcium oxalate per se, is a white or an off-white, dirty white sort color. The calcium phosphate is also common, but it comes a second after calcium oxalate. These are smooth, white, large stones, very commonly seen after infection and also as a part of Staghorn calculus. So calcium oxalate stones would normally be small when they cause pain and they come notice to the patient, because they are sharp, they cause pain, they may cause hematuria. So they, even when they're small, the person comes to know about it. Calcium phosphate stones are softer, but they're smooth, and they cause hardly any problem. So they become very large, and they keep on growing, and they may actually present with complications. And they're usually white because they don't cause hematuria so often. Now, if the stone becomes very large and it occupies at least two major calyces, right? At least two major calyces, it is known as a Staghorn calculus. So Staghorn calculus is not any large stone in the renal pelvis, is not a Staghorn calculus. The specific definition is a renal pelvic stone which extends into at least two major calyces. So there are total three calyces. So two out of three calyces, if the stone is growing into it, it is known as a Staghorn calculus. The composition obviously may vary. Then you have uric acid stones, small, hard, multiple stones, and they're yellow in color. And if they're pure uric acid stones, you cannot see them on X-ray. So if the patient with gout is having renal colic, suspect they might be having uric acid stones, and the investigation of choice in such cases would be a CT, because or an ultrasound. Even an ultrasound is good enough, but a plain X-ray would not pick up these uric acid stones. Cystine and xanthine stones are rare, but just to complete the list, I mention it here. They would occur only in metabolic diseases, because only then there are high levels of cystine and xanthine, which result in the stone formation. So how would these patients present? The major presentation is with renal colic, or more specifically or correctly, the term is ureteric colic. So these are the various sites where a stone may lodge. I will touch this again. And it may also present with hematuria. Hematuria usually is not gross hematuria. They would just present with some light pink or smoky colored urine, and then it clears off. Or they may notice the blood in the urine, which then clears off. So gross hematuria usually is not a feature. It may occur, but usually it's not a feature. In patients on aspirin or other anticoagulants, then yes, hematuria is a major presentation in these patients. So these are the two major presentations. They may present with complications. So urinary obstruction may cause hydronephrosis, ultimately may cause renal failure, and they may present with features of renal failure. Or they may be picked up incidentally, in which case they are silent stones. So we do an ultrasound for some other cause, maybe acute cholecystitis, ultrasound is done, and on ultrasound they report that he's got a renal stone also. So these are the various common presentations of renal stones. So there are 5 areas which are classically described where a stone can actually lodge and grow in size. So the ureter is a muscular tube. It has peristalsis. It has spiral peristalsis classically, which are described, and it propels the urine from the renal pelvis down into the bladder. But some areas it is narrower than the preceding area. And that narrow area you can understand is where the stone is most likely to lodge. Like a 7 mm stone may pass out through on its own, but an 8 mm stone or 9 mm stone may lodge at these areas of narrowing. So what are these classical 5 areas of narrowing? The first, coming from above below, the first is the uretropelvic junction. British books refer to this as a pelviureteric junction. So it means the same thing. Uretropelvic and pelviureteric junction means the same thing. So that is the first narrowing. That is a normal narrowing which is present in everybody. So after that, as we come down, the next narrowing is where the ureter crosses the iliac artery. And that is the point usually where the iliac artery bifurcates into the external and the internal iliac artery. So that is the point where the ureter crosses in front of the artery. And since the artery is there, the ureter gets compressed slightly, and that's the second narrowing. The third narrowing is where the vas or the broad ligament crosses the ureter. So vas in men and broad ligament in women. And this is the reddish area which is marked. There is no pointer to that area, but this reddish area which is marked in the lower ureter is the area where the vas or the broad ligament crosses the ureter. So we have covered 3. The fourth is where the ureter enters the bladder at the point of entry into the bladder, and by entry I means where it the outer wall of the bladder. That means as it is entering the muscular layer. As soon as it enters the muscular layer, that is the fourth area of narrowing. And the fifth is where the ureter ends. So right at the opening into the bladder. So that is another narrow area. So these are the 5 areas. I'll just quickly mention them again. First is the pelviureteric junction. Second, where the iliac artery, ureter crosses the iliac artery. Third, where the ureter crosses the vas or the broad ligament. Fourth, at point of entry into the muscle layer of the bladder. And fifth, at the termination of the ureter, that is the end of the ureter into the bladder. So these are the 5 areas which are the narrowest and which are the most likely to have a stone impaction at that site. So what is the presentation of this pain? I have written signs here, but I'll be covering the symptoms also along with this. There's a wrong thing where it should be symptoms and signs. So the leading symptom here is either renal pain or ureteric colic. How do you differentiate between these? So colic or ureteric colic is like it rises, increases, and it decreases. That's a typical feature of a colicky pain. And ureteric colic also follows the same. The pain increases suddenly. There is very severe pain, and then it decreases. In a matter of say minutes, 5 minutes or so, the pain would increase, be static, and then decreases. But even after the pain decreases, there is some static, continuous pain which continues. That is the renal pain. Now, the renal pain is due to distension of the capsule of the kidney, whereas the colic is due to the stone present within the muscular part of the ureter. So that means either it is at the pelvic-ureteric junction, entire length of the ureter up till the ureter end. So somewhere over here the stone is present. And why does this colic occur? Because the ureter is trying to push the stone forward, but it doesn't want to move. The stone doesn't want to move. So there is increased contraction of the ureteric muscles proximal to it, and this increased contraction causes the colicky pain. So what is the difference between these? See, the renal pain is a lower grade of pain. It lasts for a longer period of time, and it is felt typically in the renal angle. So in the flank. So in the renal angle, that you know what the renal angle is, angle between the 12th rib and the lateral border of the sacrospinalis muscle. That's the renal angle. So that is a classical site where the patient will say he's having pain, and that is renal pain. In between, the person has colics, renal colics, and that is where the pain is arising from the ureter, where the stone is present in the length of the ureter. The pain is arising at that point. So how does the patient say? Usually he would keep the thumb over the renal angle. So the right side ka hai, the right thumb he usually keeps over the renal angle, and the fingers usually point at the point where it's radiating. There is classical radiation of pain here. So when they keep their hands on the flank like this, and the patient is coming with the hand on the flank like this, cringing with pain, or he's lying in bed with the hand like this, you can straight away diagnose he's got a renal colic. There is a typical radiation of pain which is described in these cases. Now there is a bit of confusion in the minds of many students here. In renal colic, I'll speak slowly, so just try to understand what I'm saying. Sorry, I didn't get a photograph here. I should have put one here. So when the stone is present at the pelvic-ureteric junction, there is a stone only at the pelvic-ureteric junction. It causes intermittent obstruction to the flow of urine. What is going to happen? The pressure within the renal pelvis rises, so the pressure within the kidney rises. When the pressure within the kidney is rising, it causes distension of the renal capsule. The renal capsule distends, it causes renal pain. So he has pain in the renal angle. But there's a stone which is at the pelvic ureteric junction. So that stone is going to cause local pain. And now that stone will cause pain in the front of the abdomen, maybe in the lumbar area. So it causes pain. That's why the patient keeps the hand like this. But these patients would often complain of pain in the unilateral testis also. Now this is referred pain. This is not radiating pain. This is referred pain. The pain is, there is no connection between this pain. There's a pain in the renal area, and the person is complaining of pain in the testes also. When you examine the testes, you find it's normal, because the nerve roots of both the testes as well as the renal pelvis are same. They develop in the same area, then they migrate during intrauterine life to different places. So since the nerve supply is the same, the pain which is actually arising from the renal pelvis is being referred to the testes. So this is referred pain. But you have radiating pain also. Because of the ureter, it radiates along the somatic fibers. Okay. So the basic difference between referred and radiation is, in radiation there is no normal area between the start and the end of the pain, and in referred pain you have some normal area in between. So you have the origin of pain, there is a normal area in between, then you have the site of the referred pain. So in renal colic is the typical example of a radiating pain also and a referred pain also. Okay. As the stone goes down, the site of pain will keep on moving distally. And when the stone reaches the terminal part of the ureter, then again the patient would have pain in the scrotum, which is a radiating type of pain now, because the terminal part of the ureter has the same nerve root level, dermatomal supply, as the scrotum does. That is about L1, L2. Now L1, L2 level is what is supplying the distal ureter. That is also what is supplying the sacrum. So the pain which is present in the stone which is present in the distal ureter is causing pain in the scrotum. But now this is different from the pain in the pelvic junction. That was testicular pain, and now this is scrotal pain. That was deep-seated organic pain. This, when the stone is present in the distal ureter, is cutaneous pain. The skin appears that there's a pain in the skin. So this is a slight difference which is present in these cases, and possibly you can understand this when you read the book also. There may be muscular spasm. Classically, the patients are bent to the side of the pain, but there is no guarding of the abdomen. Abdomen as such is soft. Vomiting is a typical feature of acute renal colic. As soon as the patient has a colic, episode of colic, they invariably vomit. So the question which arises should be, why should they vomit? Because it has nothing to do with the GIT. Remember, any severe pain in the abdomen can cause vomiting. Even testicular pain, if severe enough, like trauma, can cause vomiting. The reason is simple. It causes a reflex pylorospasm. The pylorus reflexly closes off. And when it closes off and the stomach contracts, then naturally vomiting will have to occur. So vomiting is a typical feature. As soon as the pain subsides, the vomiting also will subside. So if we have two situations now, when the patient is currently having colics, or the patient had a colic but now he is pain free. So I'll cover both of them as the situation arises. Urine analysis is always done, although it is not very informative. What we are looking for is actually whether there is evidence of infection. Otherwise, in any patient of stone, we would expect hematuria, microscopic hematuria to occur. We would expect mild to moderate pyuria. Pyuria here does not mean infection. It just means pus cells are present in the urine. And pus cells are present in urine because the stone is abrading the urothelium and leukocytes are escaping from there. So if there is hematuria, then obviously pyuria can also occur. And then the crystals of stone, if we can identify them, will help us in determining what the cause of the stone is. So next step usually is an X-ray KUB. You can see a stone. You can see a very radiopaque area here in this stone, which is the, I don't know if you can see my marker here. Let me use a pen. Okay, so this is the stone here, radiopaque shadow. But that is not all we see. It's not only the stone which we see. You can see this line here, obliquely line, and draw it on the opposite side. So this is the line. This is the lateral border of the psoas muscle. So this gives us an orientation where the kidney should be. The axis of kidney, long axis of kidney, should be parallel to the lateral border of psoas. If it's not parallel, then there's something wrong. You can actually see the shadow of the kidney also. So this is the kidney, the shadow of the kidney, which can be appreciated. So once I see the kidney shadow, I know this stone is not in the kidney. This is a ureteric stone, which is also suggested by the longitudinal appearance of this stone. So that is the stone. Now you see some radiopaque shadows here also. You might be tempted to think that these are distal ureter stones, but no, these are phlebolyths, possibly calcified lymph nodes, or in the veins. Phlebolyths are thrombus which forms in the veins and then it gets calcified. The normal line of the ureter, first we have to learn how to calculate the vertebra. So this is the upper border of the sacrum, and you count from above this. So this would be 1, this would be 2, this is 3, and this is 4, and this here is 5, L5. The ureter will start somewhere around 3, 4. So the ureter normally follows this pathway. The normal, I'm saying, normally follows this pathway, diverges slightly laterally over the SI joint. Okay. Then here we have the ischial spine, and then from here it moves inwards to drain into the bladder. So in a plain X-ray, you know that this is going to be the root of the ureter normally. But if there is an obstruction, if there's hydronephrosis, then this ureter will move medially or usually laterally. It moves laterally. Like here in the stone, you can see it is lying slightly laterally to the path of the ureter. So this is the information we can get from an X-ray. The next step, if the patient is not having a renal colic, is to get an IVP. Okay, I got just 10 minutes more. The next step is to get an IVP. In IVP, you inject radiopaque dye, which is iodine containing. It is excreted and concentrated in the kidneys, and so you can see the ureter. Now you can see the normal pathway of the ureter on the left side. That is on your slide, it's the right side, but it's the left of the patient. And in the right kidney, you can see the right ureter also. Remember, the entire ureter will never be seen completely. You will always see some area which is not well determined. That is the normal peristalsis. Okay, and this is the normal orientation of the kidney. Remember, you should not comment on the stone, presence or absence of a stone on an IVP. See, the stone is white in color. The dye which you injected is appearing white on this X-ray. How can you appreciate white against white? So stones cannot be commented. You do an IVP for other things. You see hydronephrosis, you see the status of the other kidney, you assess the function of the kidney, but it is not done for stone disease per se. But CT has now become the investigation of first choice. That's a non-contrast CT scan. Because many radiolucent stones are picked up on CT, plain CT, without contrast, but they are not seen on X-ray. So nowadays, the non-contrast CT is become the treatment, the investigation of choice to determine whether stones are present or not. Once you know the stone are present, then you need other investigation. But for first investigation, this is a good. Ultrasound is an excellent modality for renal stones. For ureter is not good. So up to 25% may actually be false negatives. That means the ultrasound report says there is no ureteric stone, but there is actually a ureteric stone present. So you have to correlate it with the clinical findings. And the classical finding is the red. I'll just see. Yeah, this is the stone. This is the white thing is the stone. This black thing you can see here is the entire kidney. So this is a stone in the kidney. And the classical finding is that this black shadow you can see beyond the stone. So this happens because the ultrasound detector is present here at the top, and the ultrasound rays are coming out through that. If there is a stone here, no ultrasound waves can pass through it. So this creates what is known as an acoustic shadow distal to the stone. So this is the acoustic shadow, because even if there is something present here where the arrow is pointing, it cannot be picked up on stone because the ultrasonic waves have been blocked by the stone. So this acoustic shadow is a typical finding in these X-rays. A retrograde pyelography I just mentioned because somebody might have heard. It's where you place a catheter through the urethra into the ureter using a cystoscope, and you inject dye through the catheter, and then you retrograde outline the entire ureter. The advantage is that the contrast is much better. There is no dye which going into the system. So even if the patient has renal failure, this test can always be done where the IVP cannot be done. So complications of a stone primarily are obstruction causing hydronephrosis, which can further lead to infection and then renal failure. So that is what we want to avoid. Coming to management, these are three main groups. It might be medical, non-operative, or surgical. So medical management is good for small stones, less than 5 millimeter in size, or pure uric acid stones. So the general treatment is to give analgesic for colics, and the analgesic of choice is diclofenac, not an antispasmodic. It's an anti-inflammatory. The main cause is the stone, which causes local inflammation, which causes edema. So you take care of the inflammation and the edema, the pain will also subside and the stone passes. So diclofenac is a treatment of choice, and sometimes you might place a stent. That's a simple tube which bypasses the stone. If the stone, the urinary flow is bypassed by this stent, then naturally the pain will decrease. And the specific treatment is to increase fluid intake so the urine output is more than 2 to 2.5 liters per day. And a mild diuretic may be added. This Niri is one of them, which is a Ayurvedic preparation. So you can prescribe that if you wish. It just acts like a mild diuretic, nothing else. So if the stone is say up to 1.5 to 2 centimeter and in a convenient area, you use something known as extracorporeal shock wave lithotripsy. Extracorporeal means from outside the body, the patient's body, and shock waves are generated. The shock waves are just like a blast occurs anywhere. You have a thunderstorm and you have a blast coming. That is a thunder which you hear is the shock wave which is coming. Or there's a bomb blast which occurs, then the blast wave comes. So similarly, there's a shock wave which is generated. So the principle is that a shock waves concentrate onto the stone. This is a stone, and the shock waves concentrate onto it, and they cause the stone to break down, the fragment, and they break down. How is the shock wave generated? There are two or three ways. Essentially, you have this is a spark plug electrode. So there's a spark plug here. This is scooter cars वगैरह में spark plug होता है ना. So you generate a spark here. It causes a small explosion there. Their shock waves are concentrated by this reflector or wherever you want is the stone is present. And this is the actual machine. The patient lies down here. This C thing here is an X-ray. So X-rays come from below upwards, and there are this is used to localize the stone. So wherever your stone is localized by these X-rays, there this unit, this is the actual unit which touches here down below. The patient lies and this unit touches the skin. So the shock waves are generated down here and they are passed through this, through the skin onto the stone. They are focused there and then they break. And the fragments pass down through into the urine. Coming to the surgical treatment, PCNL is the workhorse. So PCNL means percutaneous nephrolithotomy. So initially you give a small cut, see where the kidney and the stone is, and pass a small needle on into the kidney to the stone. Just a couple of minutes, so I'll hurry up now. You pass a wire through this, you dilate, make this track bigger till about a 1 centimeter or so. You place a tube like this is the tube which is placed, and through this tube you can place this scope, see the stone inside the kidney, the pelvis, break that and remove the fragments through this tube completely. So this is the best surgical method because you can see the stone, make sure that all of them is removed. You can break it and remove all the fragments. Nothing is left to pass on their own. You can do the same thing by approach through the urethra. So it becomes a retrograde approach that is going against the flow of urine. So it's a retrograde approach, go through the urethra, through the bladder, into the ureter, go up to the ureter, see where the stone is, and then you break it. Commonly using laser, you can break it or you can hold it with a basket like is shown in this picture here, and you remove the stone. So this becomes a retrograde. Now this is excellent for distal ureteric stones, but you can extend this to go right up to the kidney. You can go right up to the kidney and take care of stones in the kidney when it is known as RIRS, that is retrograde intrarenal surgery. RIRS. So you are using a transurethral approach, going right up to the kidney, breaking the stone there and removing the fragments. And you have the age-old open techniques where when all else fails, you certainly have these techniques. So one is a nephrolithotomy, where the kidney is cut, the renal parenchyma is cut straight over the stone. The parenchyma is cut till you reach the calyces. You see the stone, you remove it, and then you suture everything off. Or the pyelolithotomy, which is more commonly formed, where you give an incision on the pelvis. So this is the pelvis. You give an incision on it, see the stone, remove the stone, and close off the pelvis. Then it's known as a pyelolithotomy. This may be done by open laparoscopic or robotic techniques. Usually it's a retroperitoneal approach. So which therapy should be chosen? For very small stones, medical therapy and conservative management is good. ESWL less than 1.5 centimeter, but in the kidney it's a good option. For distal ureter, not a good option because bone comes in the way. Then the distal ureter, because the bone is there, you can't localize, you can't give shock waves. For larger stones in the kidney, PCNL is the best option. For ureteric stone, URSL is the best option. And recurrent and staghorn stones, again, PCNL is the best option. So what do you advise these patients? Recurrence is very common and they are known as stone formers. And remember that if pain stops in a case of stone disease, it's not that the patient has become well or he's past the stone. Possibly the kidney is stopped functioning, and that's why the pain has also stopped. In general, the person should be advised to increase fluid intake throughout the year, and our aim is naturally to prevent complications. So these stones are common, mostly calcium oxalate. They tend to recur. Smaller ones may be managed conservatively, but endourology is the modality of choice for larger stones. Thank you very much. I'll close now because there is enough time. But quickly, if you have any questions, you can just post them here. Any questions? ESWL blocked by bone. See, shock. These are shock waves which are passing. So shock. If there is bone in the way, the shock wave will be concentrated on the bone, and the bone will fracture. So we don't want to fracture the bone. We want it to be focused on the stone. So if whenever there is bone in the way, you cannot use ESWL. The same, these shock waves travel very well through anything which is containing fluid. So most of the tissues contain fluid, so they pass easily through that. But if there is bone in the way or any hard structure in the way, the shock waves are not useful. Can there be dysmorphic RBCs on urine analysis? Dysmorphic RBCs are classically a feature of glomerulonephritis. Many glomerulonephritis is classically a feature of that. But occasionally you can find dysmorphic RBCs, but that is not not seen in all patients, and that is definitely not a diagnostic feature. Dysmorphic features are seen in other medical therapy. Could the previous X-ray be deposits in the bladder? So it was, the bladder is normally not present at that site. That was right next to the pelvic bone, iliac bone. So the X-ray is not likely to be deposits in the bladder. So the bladder has dependent. If they was present in the bladder, such small stones would have passed out. They would not remain in the bladder. Urethra has got a big lumen, so such small stone would definitely pass out. So that X-ray, I have no doubt in saying that these are not stones in the bladder. For confirmation, obviously you can do an ultrasound anytime. Testis and scrotum pain are both referred pain. Yes, both are referred pain. Okay. Uh, we don't usually do ESW and lower ureteric stone. Yes, in the lower ureteric stones, that is below the pelvic brim, ESWL cannot be done. So ESWL is never done in distal ureteric as well as in bladder stones. So even in bladder, you can't do the ESWL. So ESWL is restricted to kidney and proximal ureteric stones only. Okay. Right. Thank you. I'll just quickly close because I know that you have another class at 9. So until I close, I believe that the next class cannot start. So thank you very much. If there are any other questions, you ask me anytime. You should be having my email, the one I sent the message yesterday from. You can send a question on the email also, and I'll answer that. Thank you very much.